we wanted to get to this topic, the month of March, Colorectal Cancer Awareness Month. So today, we are joined by Dr. Stephen Rauh, a leading robotic surgeon for colorectal cancer at Rochester Regional Health. Doctor, nice to meet you.
Good morning, Joe. Nice meeting you.
And one of Dr. Rauh's patients is Stacy Ostrowski. Hi, Stacy.
Hi, Joe. Thanks.
Yeah, good to have you both here today. And so, Doc, I'm going to start off with you because, I'm always impressed, and working in the news, we often get a chance to do stories about innovations in healthcare and research and technology developments that happen here in Rochester. And Rochester, as I understand, we are a leader in the country for robotic colorectal surgery, are we not?
We are. We're actually the most experienced, meaning we've done the most robotic colorectal surgeries in the country.
And now I want people to understand what we're talking about when we refer to robotic surgery of any type. It's not an autonomous device that's doing the surgery. There's still a human element to it. If you can talk to us a little bit about sort of the technology and how you utilize that technology.
You bet. There is clearly no robot doing the surgery. It is the surgeon. The reason the term robot is used is that the surgeon is sitting separate from the patient's bedside and using the most sophisticated tool set we now have for an operating room. And the tool set still accomplishes the goal of trying to cure cancer or whatever is the indication for the surgery. So the robot just transfers the surgeon's intentions to the patient in the most precise way ever achieved.
And I would imagine with some varieties of surgery, the level of intricacy and delicacy that has to be performed. You need a surgeon's eye and art, but the robotic instruments then probably give you a much greater level of precision.
Exactly. So I often use the analogy with patients that to hang a picture, you can use a plumb bob, you can use a bubble level, you can use a laser level, and this is just the laser level. So what it allows is for us to be inside, in this case the abdomen, because we're talking about colon and rectal cancer, and see in 3 dimensions, because there's 2 cameras, that distinguishes robotic surgery from laparoscopic surgery, and close enough that we're getting images or viewing areas that we never could see before in any book or in training.
Yeah, and with the advancements in technology and camera technology and so forth, you're able to see angles within the body that give you far better access to sort of seeing what you're doing within that field of surgery.
Yes, and it broadens our options too. So first of all, it's high definition and it's remarkably clear. But also we can use other wavelengths for the illumination. And using things like Firefly immunofluorescence, that's a mouthful, but let's just say a dye, we can see how the blood supply is to areas by changing the light source from the normal light source to a near infrared wavelength light source. So it just is infinitely more adjustable.
No wonder they call this the Da Vinci surgical system. There's an art and a science that meld and mesh perfectly to come together to create this.
Exactly.
And I know that the public knows as it would be minimally invasive. Even for this type of cancer surgery, this still allows for that minimally invasive surgical procedure?
Exactly. So the minimally invasive surgery just substitutes small instruments for the former circumstance where a surgeon and the surgeon's assistant, 4 hands, used to have to work through an incision that allowed those 4 hands. Now it's, say, 4 instruments through fingernail-size incisions and with a camera and a light source so that we can see. Now, one caveat with colon and rectal surgery, the colon is the large intestine. Being the large intestine, so named because it's one of the bigger organs in the abdomen, to remove the bad part, say the part that contains cancer, to get that out, we can't get that out through a fingernail incision, so we make a small extraction incision, much, much smaller than we used to use. But I don't want to mislead people. It's not the same as having an appendix or gallbladder removed.
Right. You're still talking about a large section of a large organ within the body, potentially, that does need to be removed, and all of the other complications and other organs or systems that may become involved with that area that you have to remove.
You've got it.
This is Dr. Stephen Rauh, everyone. He is lead robotic surgeon for colorectal cancer at Rochester Regional Health. And so Rochester General Hospital, of course, would have this technology, but I know that Rochester Regional Health covers a wider area around Western New York. So this technology is available here at Rochester General, but also patients in other areas can take advantage of this?
Exactly. So Unity Hospital is the next most frequently used hospital for our practice in robotic colorectal surgery for cancer and other reasons. And their capability is out at Newark Wayne Community Hospital, and we are currently considering recruiting another surgeon to provide that service in the eastern area. So it's expanding, and we started in 2008 and we're the first to do so. So after 10 years, and over 2,000 procedures, we feel it's the standard of care and are willing to try and take it wherever it's needed.
And I would imagine the benefits that can be achieved from robotic surgery of any type. We're going to talk just a little bit about it. Of course, it's a smaller incision because the tools are smaller. You don't have to put a hand in necessarily to do what you would have normally had to put a hand into the body in order to do. So let's talk just sort of in general about if someone's going to have a procedure that would require this, what they could potentially have to say, like, well, there are some benefits to you as a result of us using this technology.
Yeah, I think the best benefits that everyone agrees on is that the length of stay and the amount of discomfort in returning to work, or if you're retired, returning to your normal activities, if you golf, travel, those types of things, usually is about half the amount of time or less than the traditional open surgery. Those are indisputable improvements. What we're learning is, at least in our data, for instance, with cancer surgery, we immediately started getting a larger lymph node sampling, which is so important when you're taking care of cancer to identify those lymph glands or nodes to help us stage the cancer and provide the proper treatment should other treatment be needed. And in our early data, and it's stood up, we were getting more lymph glands with this technology. And
also, I would suspect your potential or level or rates of infection are also impacted positively as a result of the type of precision in surgery that you're able to do.
100%. No disagreement there. You are correct.
Yeah, and of course, it's you've got a smaller scar to have to worry about, especially when it's bathing suit season. And robotic surgeries, I would suspect, have increased in their application as well, so that the technology is now being able to be used sort of multidisciplined and across numerous fields of treatment, correct?
Yep. So Rochester General and Rochester Regional Health are number one in colon and rectal robotic surgery, but also top 20 in the country with respect to prostate surgery, I believe general robotic surgery, and I think gynecologic surgery. So, and in our field alone, we're using it for treatment of diverticulitis, treatment of Crohn's disease, ulcerative colitis. For instance, in our practice, we found that diverticulitis, which can be a challenging surgical procedure, we have less need to convert to open, which means go from the minimally invasive laparoscopic procedure to the traditional open due to the difficulty of the situation. Those conversions are much less with robotic laparoscopic than the prior laparoscopic surgery.
And I would imagine for as far as patient outcomes, whenever you have the ability to do more with less, as it were, that's better patient outcomes, that's better recovery time, that's just better overall for everyone.
No doubt about it. The nurses that have been on the floor for the both before and after are still sharing the amazement that I still have.
This is good. This is a great story to share. March is Colorectal Cancer Awareness Month, and so Dr. Stephen Rauh is with us. He's lead robotic surgeon for colorectal cancer at Rochester Regional Health. And after our break, we're going to meet one of Dr. Rauh's patients. That is Stacy. We're going to talk about her journey through her surgery and what it was like to go through this procedure herself and come out the other side. And we'll discuss that when Rock Health Radio continues. Next on News Radio Wham 1180. Welcome back to Rock Health Radio on News Radio Wham 1180. March is Colorectal Cancer Awareness Month, and today we are joined by Dr. Stephen Rauh, who is the lead robotic surgeon for colorectal cancer at Rochester Regional Health. And I want to turn things over now to one of Dr. Rauh's patients. That's Stacy. Hi, Stacy.
Hi, Joe.
It's good to have you on the program here, and you are a patient. You have come through, so we're going to get to your end game in a bit, because I know you have had this robotic surgical procedure done for you for your cancer. But take us back to the beginning of your story, if you would. Where were you health-wise when you started your path that led you to Dr. Rauh in the first place?
I was actually very healthy. I had an issue with acid reflux and went to the doctors, and after that happened, she asked me about some family history of cancers, and I said, well, breast cancer, ovarian cancer, and she says, anything about colon cancer? I said, no, but my parents both had polyps removed, and she goes, well, you're not at the point where you need a colonoscopy yet, but due to your history, you should think about having a colonoscopy. So I talked it over with my husband, and we're like, yeah, well, better safe than sorry, and lo and behold, I had a colonoscopy, and there was a tumor there.
Wow. And to have that diagnosis, because I'm a cancer survivor myself, not this particular type, but when you first have that sit down with the doctor, what was that sit down like to you when they come back and they say, okay, we need to talk about this, and it's the C word. It's the big capital C word that many of us, either hopefully we can have the discussions about, but many people don't like to have the discussion about.
Yeah, at first, I don't even remember the conversation because I was in such shock, and I was told could be cancer, could not be cancer, go see a specialist. So I went to see Dr. Rauh, and he's like, yes, we should probably get this out of you sooner rather than later because it is ugly and it does not look good. Mm-hmm. And I put my health in his hands, and I'm here today.
That's a great thing about being able to trust your team, because it's not just one doctor, it's everybody that all goes together, and to know, okay, I'm going to surrender my control of this situation over to those who know more than me that can really help me, and now you just start going along for the journey. From diagnosis to surgery, though, how long was it? Was it really very quick turnaround?
2 weeks.
That's fast, and so you're getting yourself sort of mentally prepared for what's going to happen. How was it working with Dr. Rauh? What was he mentally preparing you for, or getting you set for as you were going to get ready for the surgery?
It was amazing. Both myself and my husband, we had tons of questions, and we were very nervous. And we went in for the pre-op and met with Dr. Rauh, and he explained everything from A to Z, beginning to end. He asked us questions. He let us ask him questions. He explained things we wouldn't even think to ask about. And he actually had a pamphlet that showed your colon and everything in there. And he pointed out where he's going to be looking, what he's going to be taking out. And I had that with me, and we studied that. And we were totally prepared.
Yeah, because I would imagine it's, when you get told there's a tumor, this needs to be removed, your mind may make a picture of, okay, this is what it's kind of going to look like. This is about what the size of it is, and this is what they're going to have to do. And then maybe that is the case, and maybe it's different by the time you get there. Was there any explanation beforehand to say, like, okay, we're going to be taking about this much, to give you a mental picture of what was going to happen when you woke up?
Yes, he said we'll take probably 12 inches of your colon, the part that's near the small intestine, and your appendix will come out too because that's attached to it. And it's going to be about yay big, but we'll sew you right back up. You'll be fine. The colon will be perfectly working. I mean, worst case scenario, this, that, and the other thing. But yeah, he laid it all out, and we had a very good picture of what was going to happen and felt very reassured.
Talk to me about how the robotic procedure was explained to you. I mean, I have an idea of what surgery is. It's cut open, root around inside, fix what's wrong, sew you back up. I mean, that's a very rough description of it, of course, and I'm not a surgeon or a doctor. But talk to me about how that robotic procedure was explained, as well, how that was going to work for you.
Sure. Dr. Rauh explained that there will be, I think it was 4 instruments that would go in through 4 holes, one through my belly button and then 3 others. And it would come in from one side, and they'll be operating on the other side. So don't wake up and think, oh, they took out the wrong side of my colon because the holes are on the wrong side of my body. So that was reassuring.
That's very reassuring, yes.
And then, like Dr. Rauh said, just a small incision to actually take out the organ that had the cancer in it. And he explained it, showed pictures, could ask questions anytime, even after the pre-op. And it was very, very informative and reassuring.
This is Stacy Ostrowski, everyone, a patient of Dr. Stephen Rauh, who, by the way, is the lead robotic surgeon for colorectal cancer at Rochester Regional Health. Since March is Colorectal Cancer Awareness Month, we're sharing this story this week on Rock Health Radio. Stacy had that robotic surgery to remove a 12-inch piece of her colon and some related systems that are there, because the idea behind the tumor is that some of us who might think it's just one thing and it can be very easily taken out. It's just this one piece. It's like you just remove it, you put the two ends back together again, and that's it. But there can be other involvement. And I assume that was part of the explanation before the surgery is that, okay, this is where it is, but here's the area we have to go to make sure that you are, as best as we can tell, cancer-free when the surgery's over.
Yes, definitely. He took a little bit of the small intestine where it connected to the large intestine and a whole bunch of lymph nodes to make sure that the cancer hadn't spread. If it had spread, you could detect that in the lymph nodes. So he went far enough above, and then it was towards the end, so where the appendix is, so he just took the end too. Mm-hmm. But far enough above, so if we did find that it had spread, he wouldn't have to worry about, did I get it all the way to the edge of the tumor or not?
Right. And having to go back and potentially do additional surgeries there for cleanup. Now, as the doctor mentioned in the first set of our program, we call this type of a surgery as a minimally invasive surgery. And as you mentioned, there were 4 incision marks for you. Was that it? There was no additional need for any other marks, or any other type of healing externally that you had to do?
No, not at all.
Wow.
No, it was just 4 small, couple little stitches up, some tape on it or whatever, and that was good to go.
That was that.
Yeah.
So let's talk about the recovery part of that. And I don't know whether you'd had other surgeries done for other things in the past, so I don't know if you have anything to compare it to. But recovery-wise, when did you feel that, you know what, I'm not so acutely aware of the fact that I've had this done anymore. I'm just sort of moving about my day, my home, getting back to work?
I was up and about I was out of the hospital within a few days. And I was up and about my house within a few days after that, but I didn't return to work for 4 weeks just to be safe and make sure I didn't, wreck the good work that Dr. Rauh did,
Exactly.
and to make sure I didn't overexert myself.
Exactly. So was it really kind of a noticeable thing, or were you aware sort of mentally, I've had this procedure done, but honest to goodness, I don't really feel much difference.
Yes, definitely. The only thing that would remind me of it every day is when I would take a shower and be like, oh yeah, I had something done down there. As far as pain or, I wasn't supposed to lift anything, but pain and moving around, I was ready to go.
And I'm not going to call this, because I would do this. On your iPhone, you have a picture of what was removed from you. Is that kind of like a badge of honor for you now? That's like, you know what? I beat this. Here, let me show you what I beat. Boom, here it is.
Yes, it is. I show it to anybody who asks me about it. And I begged Dr. Rauh and signed off on it. And I said, please take a picture of this. I need to see what you took out of me and what it is so that I can say goodbye to it.
Yes.
And I can tell people, go get a colonoscopy.
Yeah, exactly. I think before we wrap up here, regardless, you had a family history, and it's good that you had that discussion with your doctor, and your doctor sort of connected the dots and said, yes, I encourage you, please go do this. And you could have very well said, nah, I think I'm okay with this. But you went ahead and did it anyways. So, just in our last 60 seconds here, here's your chance to pitch it to anybody that you'd like to out there listening about whether they're maybe not thinking about it, thinking they're too young, or thinking their family history doesn't matter.
It's worth it. Don't worry about the prep work. It's done and over with before you know it. The actual procedure for a colonoscopy is done and over with before you know it, and you get your clean bill of health. You're good to go. You don't have to worry for another 5 years. You got to have the peace of mind, or they could find something and your life is saved.
All right, so when we come back, we're going to talk more about prevention, about screening methods with Stacy Ostrowski, who is a patient of Dr. Stephen Rauh, who is the lead robotic surgeon for colorectal cancer at Rochester Regional Health. March Colorectal Cancer Awareness Month. So we'll continue our discussion on Rock Health Radio right after this. We are honored to have Dr. Stephen Rauh with us. He's the lead robotic surgeon for colorectal cancer at Rochester Regional Health. One of his patients, one of his successes, is Stacy Ostrowski, who had the surgery done. How long ago did you have that robotic surgery to remove that large intestine tumor for you?
My surgery was in April of 2016, so I'm reaching my 2-year mark.
Congratulations.
Thank you.
2 years cancer-free. Every day is a milestone, and every year is an even bigger one. How are you feeling overall?
I feel excellent. I have no repercussions, nothing, and I've, been living life.
That's cool. Did you just go back for a tune-up every now and again with Dr. Rauh?
I went back for a 1-year follow-up just so he could go in and check and make sure nothing had regrown and make sure the part where he put everything back together was looking good, and I got a clean bill of health, and I'm good to go for another 3 or 5 years.
Oh, fantastic. Absolutely.
Yeah.
So Dr. Rauh, let's come back to you. And, as Stacy mentioned when she told her story, most people do believe, and most, I think, sort of general family doctors will tell you that first time you need to think about really screening for colorectal cancer is about age 50. That tends to be what I've heard as sort of the standard. True or false on that?
True.
Okay.
But.
And how appropriately use that word.
Exactly.
I love a colorectal surgeon with a sense of humor.
Well, 50 is the actuarial and insurance guideline.
Got it. Okay.
It's certainly not for everybody. For instance, African Americans, for the most part, should be started at 45.
Okay.
That's not widely adopted by the insurance companies, but those of us taking care of colon and rectal cancer, or more importantly, trying to prevent colon and rectal cancer, as it is preventable, would, without a question, be willing to screen an African American in their late 40s before 50.
Okay.
The other thing that's become apparent in recent years, and there has been some late press about this, you and your listeners may be aware of this, that the age of onset for polyps and colon cancer seems to be getting younger. And ironically, just this week, I took care of a 22-year-old who fortunately was found at the point she had precancerous polyps.
Okay.
But all of us that take care of colon cancer have people in their 20s and 30s and 40s, like Stacy, who you would not have identified if you had just waited. And that's the challenge, because we can't screen everybody from age 21 on due to cost. And the procedure is not risk-free colonoscopy,
right,
even though it's extraordinarily safe. It's safer than driving a car in terms of the number of times there would be a, quote, accident.
Right.
But we need to have a low threshold to check somebody when a situation comes up that is not perfectly fitting guidelines, no family history, no symptoms, et cetera, then we'll wait till 50. But Stacy had a family history, and we like to check people at least 10 years before that first-degree family member had their colon cancer, say. Mm-hmm. So if, for Stacy, I would recommend that her children be checked in their 30s.
Right. With that near family history,
correct,
of that, and you're right. You know what? I've had 2 colonoscopies. I'm not 50 yet. I started mine at age 40. Thank goodness. And I will say thank goodness that I had a symptom of something that was unrelated, but got me the test that I needed to get started on that. So I'm very grateful. I think, Stacy, for you, it was kind of the same way. The symptoms that you were having, you didn't quite know how to identify what was going on, but fortunately your doctor said, we need to move to this. Yeah,
actually I had no symptoms that would warrant a colonoscopy, no outwardly symptoms. Mm-hmm. It was just the family history, and that was enough to make me say, yeah, I should probably get it checked out just to be safe.
Just to be safe. Yeah, and I'm grateful, too, because I wound up with one of the polyps they found with me, precancerous, but since then, just polyps, which is good. So sign me up for every 5 years. I'd be more than happy to go back in. It's a brilliant nap, by the way. A colonoscopy is an absolutely brilliant nap. So let's talk about risk factors, doctor. Let's talk about, age, of course, not necessarily. You can start later in life. It can start earlier in life, depending on health and family histories. But let's talk about some of the other risk factors people should be aware of when it comes to whether they need to possibly talk with their doctor about pursuing further testing.
Very important. The first thing I'm going to say is that most people don't have obvious risk factors. 90% of colon cancer is what is termed sporadic. That means there's no family history, and the person has no predisposing other factors. So the factors that do occur in about 10% of people would be a first-degree family member, that's parent, sibling, or child that has had colon cancer. And then there are some genetic conditions that definitely predispose to colon cancer. Excuse me. One would be something called polyposis, and all those people will have colon cancer by their 50s if they don't have their colon removed. That is a condition that's passed along from parent to child to the next generation and causes hundreds of polyps. Not common, but that's certainly a predisposing factor. One debunked myth I would like to say is that while diet could be a factor, it's not something you can use to control this. So it's certainly, you want to have a healthy diet, but you can't prevent colon cancer by just eating a healthy diet. That's not enough.
So it wouldn't be a question of, well, you know what, my fiber intake is through the roof, and I'm doing all the good fruits and vegetables and so forth. I should be fine. It's certainly not the case. And that is one of those types of things that I don't know whether it is necessarily a pervasive myth that's out there, but it is something that you can even casually hear about in conversations that may not have any good medical basis.
Agreed. So the other thing about being on a good diet, probably most of us weren't on a good diet for our first 50 years or as good. And you can't take that away because that goes into what is happening to our bodies over time.
Okay.
Don't get me wrong. I definitely agree. A good high fiber, low fat diet, it's good for the gut. It may well have a positive impact on the risk of polyps and cancer. But people say, what can I do? And I say, get screened, get your colonoscopy, find out if there are polyps there that you won't know about because you won't feel them and they won't bleed or cause changes until they get to a point that really is often the horse is out of the barn.
Exactly. This is Dr. Stephen Rauh, everyone. He's lead robotic surgeon for colorectal cancer at Rochester Regional Health. Joining him, one of his patients, Stacy. And since March is Colorectal Cancer Awareness Month, we're talking about not only the disease, but the treatments and the great technological advancements that have been made in treatments and surgical options that are available here through Rochester Regional Health. I want to back up just a little bit to talk about sort of colorectal cancers in general. It seems to me that by the time I had my first colonoscopy at age 41, the polyps they found relatively small. And I don't know how long it took for them to actually grow and develop. Are colorectal cancers, do they tend to be more or less aggressive than, say, breast cancers, lung cancers, other types of cancers?
I think generally they're slow growing and more curable when they occur, and without a doubt, incredibly more preventable. So let's just think about screening. When we screen for prostate, lung, cervical, well, cervical not so much. I'll say prostate, lung, breast.
Okay.
We're trying to catch cancer early, but it's already cancer.
Oh, okay.
But polyps are not cancer. Cancer means it can spread and kill you. A polyp, before it becomes cancer, can't spread and kill you.
So the polyps then are localized just to that one small area. So taking that area and a little bit around it pretty much is all that needs to happen.
Correct. And the polyp itself not being cancerous, it's considered a benign problem. Removing it completely eliminates the chance that that polyp could become cancer. Now, not all polyps become colon cancer, but all colon cancers come from polyps.
Right.
So the current state of the art is to get rid of the polyps. That gives the person the best chance at preventing colon cancer. Not even catching it early, but preventing. Separating colon cancer from so many other types where we just try to catch it early.
Right. And this is the type, when you talk about screening and detection, there are other types of cancers that, let's say, would manifest on a blood test. As an example, I had testicular cancer, and they were looking for what they call, I think, a beta HCG marker in blood. Now, that's a big technical term. You don't have to know what that is, but they didn't have to go in and do a biopsy on me. They could find it in the blood. When it comes to colorectal cancers, pretty much the colonoscopy is that standard to be able to go in, because you can actually go in and look and see the field of what you're looking at to make sure, is it clean, is it not clean?
True. Let's go over a little bit of the other screening tests. All screening tests are better than nothing.
Okay.
So there's the doctor doing a digital exam, checking the stool for blood. There are x-rays, a lower GI x-ray, or what's called a CT colonography, which is a type of CAT scan that can pick up polyps and cancer. All of those are much better than nothing. But none of those can remove whatever is found. So if something is found, that person who maybe was choosing to hopefully avoid a colonoscopy for whatever reason, they're going to be recommended to have a colonoscopy because something was found.
Yeah.
That's why colonoscopy is still the number one most common screening, because it can remove polyps when found.
Exactly. And once you're in there, get them out. And then get on the protocol and talk with your doctor and have the discussions about what are we going to do now going forward. Whether that's going to be every 2 years, depending on your family history, if it's going to be every 5 years or 10 years or what have you, start having the discussion and get yourself screened. And it doesn't matter that the month of March is running out, everyone. I mean, I know March is Colorectal Cancer Awareness Month, but any time is a great time to have this discussion with your doctor. And we are here with Dr. Stephen Rauh, who's the lead robotic surgeon for colorectal cancer at Rochester Regional Health, and Stacy Ostrowski, one of his patients, our guest too. We are back to wrap up our discussion of March, Colorectal Cancer Awareness Month. And Dr. Stephen Rauh is here with us, lead robotic surgeon for colorectal cancer at Rochester Regional Health. Rochester Regional Health, really a nationwide leader in this advancing technology for cancer treatment, cancer surgery. Not only here at Rochester General Hospital, but throughout the Rochester Regional Health system. You can take advantage of this. Stacy Ostrowski is living proof that the robotic surgery can have some amazing outcomes. Almost 2 years, you said, or a little over 2 years post surgery, and doing great as a result of what Dr. Rauh was able to do for your colon cancer.
Yes, 2 years next month.
Okay, all right, 2 years next month. So I'm gonna give you the floor for just a second here to remind folks about, you know, your story started, you know, maybe very innocently enough with a symptom that wouldn't necessarily have led your brain to think colon cancer, but to just remind, you know, our listeners out there that you don't necessarily have to have something that would be a giant red flag to start having that conversation with your doctor.
Yeah, totally not. I went in for something totally unrelated. I was having acid reflux issues, but the nurse asked me, is there any history in your family of any type of cancer? And, you know, I have, you know, aunts that have breast and ovarian. And then I got to thinking, you know, I'm like, well, you know, there's nothing in my parents with cancer. I go, yet, you know, they were always going in for a colonoscopy and getting polyps removed. I always remember, oh, you know, I had a few polyps removed. So I was talking to the nurse about that, and she goes, well, you know, the history of your parents having polyps, we should probably take a look, see if you are susceptible to that, if you have any issues with that, and let's get you a colonoscopy scheduled if you'd like, and see what's in there, and just be preventative and be better safe than sorry. Mm-hmm. And I was like, you know what? That's probably a good idea.
Well, what a great decision you made, and what a great bit of advice, you know, not only from your doctors, but Dr. Rauh will bring you back in. Great level of care, not only technologically, but you know, staff and the team that are working through Rochester Regional Health to bring these patients through something that can be very emotionally difficult as well as physically challenging to have this type of, you have to have a piece of your body removed and now live life past that point.
Agreed. Joe, sometimes I talk about the analogy of landing an airplane. The pilot gets a lot of credit, but think about what went into getting that airplane built, maintained, getting it off the ground, the air traffic controllers, all the maintenance people. It's extraordinary what's behind the safety of the flight, and the same is true with a major operation. It takes people at all levels, administratively, right down to the technicians, and I'm very fortunate. I've worked at what was then just Rochester General, now Rochester Regional, since 1982, and the dedication and esprit de corps in the operating room has been an area leader in my career. And the team that we have formed doesn't feel that robotic surgery is something, on the edge. Mm-hmm. We feel that it is appropriate and routine, not to make it minimal, but that we have come to a level of sophistication and comfort in providing this that through everybody's help and our team, we can accomplish good outcomes.
And Rochester Regional Health and Rochester General really leading the way, sort of nationally in sort of setting that standard. I'm as I mentioned when we started the show, I am always impressed when we cover news stories about the technological advances, the research advances, the patient care advances that we have been able to make in this community through the healthcare services of Rochester Regional Health to provide better outcomes and better quality of patient care. And regardless of what that is, whether that's information that goes into your brain or a piece of technology that you can then extend your hands into an area that your hands can't really reach the same way.
True. I think about it all the time. It's a gift to be living in this era as a provider as well as a patient.
And just before we wrap up here, there are plenty of resources that are out there for people that they don't know whether they should be screened. They don't know about what's available to them out there. The first resource I'm going to recommend to you is just go to rochesterregional.org. That's the homepage for Rochester Regional House. If you click on the services tab, you'll find the wealth of services that Rochester Regional Health provides. Click the cancer tab too as well. Are there any other places, Doctor, that you might recommend people if they just want to start having that conversation with themselves maybe before they have that conversation with their doctor? Because sometimes going online is an easier thing for folks to do. Any place that you like to go and send your patients when they're looking for information?
Well, in general, online information in the health field is very good compared to 15 or 20 years ago, where I would have routinely said to patients, just be careful what's online, and I still say that, but I didn't have the confidence that I do now that you can access good information. And all the major medical centers, including Rochester Regional, have excellent sources of information. But I suggest just talking to people that you're comfortable with and trust. Of course, your doctor, but Stacy talked to the nurse. And that's another person that maybe when the doctor was in there, they were on some other part of the subject. And so Stacy took the opportunity to discuss that with the nurse, but also consider just talking to friends and family, your neighbor, and just say, did you get checked? You're going to be amazed at how many people, quite frankly, whose lives were impacted in ways they don't even realize because they are not going to have colon cancer. They're not going to be impacted. Colon cancer is the second most deadly cancer in adults of all.
All because of people not getting screened?
Now, correct. Mm-hmm. That's right. Because we have that knowledge now that we should be able to reduce almost all of them.
All right. Have the conversation. That's what it really comes down to. Dr. Stephen Rauh, thank you very much for joining us. Dr. Rauh is lead robotic surgeon for colorectal cancer at Rochester Regional Health. It was a pleasure talking with you.
Appreciate being here.
Stacy Ostrowski, congratulations and continued year after year of health.
Thank you, Joe. Thanks for having me.